Hello everyone, myself Dr. Ebin Thomas, first year PG from Department of Radiology, Pushperi Medical College, and we will be discussing about the normal chest X-ray evaluation today. So, chest X-ray is a very common investigation which we go through in our day-to-day life, and it is a very important investigation. Regarding the importance of interpretation of chest X-ray. Chest X-ray is one of the most common image-based questions asked for various exams. So for the students who are going to appear for various entrance exams, you can expect some questions from the chest X-ray, image-based. So reading an X-ray is equally important academically and clinically. Most of the clinical departments will have to deal directly or indirectly with the chest X-ray. Chest X-ray is one of the commonest investigation we as doctors are asked to for expert opinion by our relatives or neighbors. So therefore, having a proper knowledge on chest radiograph is more like a necessity for us. In the upcoming sessions, we will be discussing on this important topic of reading a chest X-ray divided in two short sessions. The first session we will be talking about normal chest X-ray, and the second session we will be talking about the commonly encountered abnormalities in a chest X-ray. So first we will be talking about a normal chest X-ray. Before talking about a normal chest X-ray, let's just see how a chest X-ray looks like. So in this image, you can see there is a white. This is a bone, and as we all know, bones are radio opaque. So this is how a bone looks like in an X-ray. This is air, and air appears translucent, and this is water. So this is how these structures look like on an X-ray. This is how a chest X-ray looks like. So you can see and the various structures seen in this radiograph. If you look at from top to bottom, this is the clavicle. This is the clavicle. This is your upper limb, namely humerus, clavicle. This is the right clavicle, right humerus, left clavicle, left humerus. Then you can see the trachea, the radiolucent structure. Then you can see the vertebrae. You can see the ribs. And the heart, the diaphragm. So what all do we have to look for in a chest X-ray? To know what is abnormal in given something, we should know what is normal first. So that's the relevance of knowing about the normal chest X-ray. In order to know what problem does the patient have, we must first know how does a normal chest X-ray look like. That's where the importance of knowing how a normal chest X-ray looks like comes into play, and the importance of this session thereafter. A structured way to look for the structures in a chest radiograph is to be discussed in the next few slides. So, as we already discussed, this is trachea T, as you can see. This is ascending aorta. This is aortic knuckle. This is ascending aorta. This is the heart. This is the lungs. And this is the liver. A normal chest X-ray, what all do we see? The lung fields, the mediastinum, diaphragm, and you can see in the other part of the image the heart is being shown and aorta is arising from the left ventricle. So, normal chest X-ray and diagrammatic depiction of mediastinal structures. See, this is the trachea, and you can see the aortic arch, the left hilum, the right hilum, and the right main bronchus. You can see the superior vena cava just parallel to the trachea, the right atrium, the pulmonary artery branches, the left atrium, and the left ventricle. This is a diagrammatic depiction of mediastinal structures, and mediastinum is a very important topic in a chest X-ray. In this image, you can see the various structures forming normal mediastinal borders. As we all know, the right heart border is formed by superior vena cava, right atrium, and inferior vena cava. And here you can see ascending aorta, the right pulmonary artery branch, and the right atrium. This is the left subclavian. This is the aortic knob or aortic knuckle, the left pulmonary artery, the left atrial appendage, and the left ventricle. These structures from the left heart border, and the structures thus are very important. So when we look at a chest X-ray, PA view or AP view, there are some things which we should definitely look at and report thereafter. The first thing we should be looking at is whether the trachea is central or not. Normally, the trachea may be mildly shifted to right or central, but it should not be grossly deviated to shifted to right or the left. If it is shifted to the right or left grossly, that means there is some pathology. So trachea should be central. The bilateral lung fields should be clear. Cardiomediastinal shadows appear normal. We already know what are the mediastinal boundaries. So we should look at the cardiomediastinal shadows, which should be normal. The cardiophrenic and costophrenic angles should be normal. This is the cardiophrenic angle. It should be clear, and this is the costophrenic angle. Here between the diaphragm and the ribs, both of which should be clear. And then we should comment on the bony cage which we see on this radiograph. And in the end, the surrounding soft tissue appears normal. As we already discussed, on a chest X-ray PA view, right head border is formed by superior vena cava, right atrium, inferior vena cava, and left head border is formed by aortic knuckle, pulmonary bay, left atrial appendage, and left ventricle. Basic projections of chest X-ray views. So common projections used by us clinicians include chest X-ray PA view, that is postero-anterior, chest X-ray AP view, chest X-ray lateral view, and lateral decubitus view. The X-rays are directed from posterior to anterior direction in relation to the patient in case of PA view, whereas the X-rays are directed from the anterior to posterior in case of AP view. The tube to film distance in PA view is around 6 feet. Chest X-ray PA view is the standard technique or universal convention of doing chest X-ray. It can be done using two techniques, low kVp technique and high kVp technique. In low kVp technique, we use 60 to 80 kilovolt, high contrast image is obtained, and low kVp technique is useful for calcification or miliary shadows. The high kVp technique, we use 120 to 170 kilowatt. There is high penetrating image. The penetrating power is high, and this is used for evaluation of hidden areas. How we take a chest X-ray PA view? The patient is asked to embrace the cassette or keep both hands on the waist and droop shoulders. Thus, the scapulae are drawn outward or laterally. Thus, the scapulae are not going to overlap much over the lung field, and we get a clear view of the lung field, which is what our priority is rather than looking at scapulae when we go for a chest X-ray. The patient should be in erect position, and the patient should be asked to take deep breath and hold his breath while taking the image so that the lungs are maximally filled with air, that is suspended end inspiration. The patient should be in suspended end inspiration while taking the image. The expiratory chest X-ray is helpful in case of suspected pneumothorax or air trapping. Otherwise, we ask the patient to take a deep breath and hold his breath. Although PA view is a standard technique, and most of the references are made with PA view in consideration, there are some exceptional situations where it is not feasible, where the PA imaging is not feasible. That is, first, infant, polytrauma or unconscious patient, major bypass surgery and major brain surgery. In all these conditions, the patient can't stand erect. So, in these situations, we take an AP view, and on comparing with the PA view, the AP view tube to film distance is shorter. As you can see, this is the PA view, and you can see the scapulae on both sides are seen in the periphery of thorax. You can see this is the scapula, and you can see it is not overlapping the lung field. The clavicles project over the lung fields. The posterior ribs are distinct, and if you see an air fluid level in stomach, it is an upright film, and PA view films are taken with the patient upright or erect, as we have already discussed. Now coming to the AP view, you can see the scapulae are above the lung fields. See, the scapulae are above the lung fields. The clavicles are above the apex of lung fields. And anterior ribs are distinct. Normal standards for the following are in PA view only, as we have already said. Gravity changes them in AP view. The cardiac size, the width of mediastinum, position of diaphragm, the meniscus of pleural effusion and vascular shadows are not seen in the AP view as seen in the PA view. Now, supine AP. As we already said, there are some cases in which PA cannot be taken, like infants, and polytrauma, and seriously ill patients, post-major brain surgery. In that, we take supine AP view. The heart appears larger, which is known as apparent cardiomegaly. The mediastinum widens. The diaphragms are higher. The pleural effusions layer posteriorly, as fluid always settles down to the dependent part, and when we lie down, the posterior part is the dependent part of our body, so pleural effusion layers down, and pulmonary vessel size is same in the upper and lower lung fields. Now, there are certain things that we should look at to see whether the image is a quality image. One of those things is the centering optimum, or is the film rotated to any side? Because this is very important, because we may misdiagnose or wrongly diagnose some pathologies which may be appreciated falsely due to the rotation. So, whether the centering is optimum or not. And to look at that, we draw a line passing through the spinous process of the vertebrae, and this central line should be equidistant to the medial ends of clavicles on both sides. This is the medial end of clavicle over this side, and this is the medial end of the clavicle on this side, and this is the central line, and the medial ends of clavicles should be equidistant from the central line, which is passing through the spines of the vertebral bodies. If it is not equidistant, it is said to be a rotated film. Now, let us see. In this image, we are shown the hilum. This is the right hilum, and this is the left hilum. And the thing which is to be noticed is that the lower margin of left hilum is at the level of upper margin of right hilum. That means left hilum is always at a higher level than the right hilum. About the hilum, each hilar point is the angle formed where the upper and lower lobe pulmonary vessels meet. These are useful points of reference to determine the positions of the hilum. Commonly, the left hilum is higher than the right, as we discussed, and the normal carinal angle is 40 to 80 degree. The carina is the point at where bifurcation of the trachea into right and left bronchi occurs, and the normal carinal angle lies in the range of 40 to 80 degrees. This is what we said. This is the trachea. This is the right main bronchus. This is the left main bronchus, and this is the carina, where the trachea bifurcates into right and left main bronchus, and this is the right upper lobe. So, when you see a chest X-ray, the normal chest X-ray shows vascular markings which are more prominent in the base of the lungs when compared to the upper lung fields. If you can see in this image, this is the division, and this is the upper lung field, and this is the base, and you can see the vascular markings here are more prominent than those which are seen in the upper lung fields. And there is paucity of vascular markings in the outer third of lung fields. If you can just observe over here, the middle 2/3 of the lung fields show increased vascular markings, and the lateral 1/3 or outer 1/3, there is a well appreciated paucity of vascular markings, uh, and this is a normal thing which we see. And if you see increased vascularity in the outer one third, that means there is some pathology, and that's why I said that knowing the normal is the first step to read a chest x-ray. And the outer one third showing increased vascular markings is called pulmonary plethora, which is seen in various conditions, which will be discussed in the next session. So for now, let's continue with our topic, that is normal chest x-ray. And you can see this is a female patient, and about the vascular markings, the normal breast shadows also have a role to play. The vascular and interstitial markings appear more prominent over breast shadows. See, these are the breast shadows. You can see over here. And the vascular and interstitial markings over breast shadows appear more prominent. See, you can see over here. And these should not be misinterpreted as increased bronchovascular markings. This is particularly true with the lactating breasts, where there is increased prominence over the breast shadows. And to just confirm, if you take a lateral chest x-ray, the markings will be normal because there is no superimposition of the breast on lateral imaging. The next thing which we have to look for a quality image is about the exposure, if the exposure is appropriate or not. In this image, yes, it is appropriate because you should barely see the intervertebral space. See, this is the intervertebral space, and with correct exposure you should barely see the intervertebral space through the heart. See, we are barely seeing. If you see them very clearly through the heart, the film is overexposed, and if you do not see them through the heart, the intervertebral space, it is underexposed. So that's how we comment on the exposure of the film, by looking at intervertebral space through the heart. If it is barely visible, it is appropriate exposure. If you do not see the intervertebral space through the heart, it is underexposed, and if you see them clearly, it is the image is overexposed. If you look at this image, this is not appropriate exposure and this is overexposed, and you can see the intervertebral space through the heart. You can see over here. See, in this image you could barely see the intervertebral space through the heart, and in this overexposed film you can see clearly. So it is overexposed, And small lung lesions may not be detected in overexposed film. Lung fields will appear dark in overexposed films and can be misinterpreted as emphysema. Interstitial markings may appear prominent and can be mistaken for interstitial disease in underexposed film. And now, how we can comment on the ribs seen in images. If you see, these curved ribs are the anterior ribs, and you have to number 1, 2, see, and the arrowheads over here in this part of the image point to the superior margins of posterior ribs. So these are the anterior ribs and these are the posterior ribs. And then if the patient had adequate inspiration during the time which image was taken, and for knowing whether there was adequate inspiration or not, the dome of the diaphragm should be over 10th posterior rib with full inspiration. Improper inspiration, you can see the dome of the diaphragm is much well above the 10th posterior rib. So there is improper inspiration, and due to improper inspiration, the mediastinum appears wider, the heart appears enlarged, lung markings appear prominent in base of lungs and can be mistaken for interstitial disease. So it is very important to know whether it was adequate inspiration or improper inspiration, or else we may misdiagnose a normal chest as an abnormal. And just like we discussed, here is the costophrenic angle, and if you see any blunting, usually these angles should be clear. If you see any blunting, it can be either due to pleural fluid, that is pleural effusion, which settles into the most dependent part, and or fibrosis. Now about the aortopulmonary window, just like we discussed, this is aortic knob or knuckle. This is the aortopulmonary window between the aortic knob and the pulmonary artery. So, thank you, and we will meet again in our next session, which is abnormal chest X-ray. Thank you. Happy learning.